If you're a support worker, okay, you have a right to two things that are generally not provided to you in mental health systems. One is a reasonable enough caseload so that you can actually work on people's recovery with them. And when you're working, those of you who work in the trust are getting fairly reasonable caseloads to be able to do that. The other thing you have a right to is ongoing knowledge and training and information. And one of the things I love to see staff do in professional situations where they're working is to get together and go to the leadership of their organization and say, we have a right to ongoing training and information. Because look at it this way. It is absolutely appalling that if I had a diagnosis, a very early diagnosis of cancer, and a particular cancer that was quite treatable, okay? And I could go, I should be able to expect that whether I live in Liverpool or whether I live in Birmingham, I can get a reasonably similar program of treatment so that the cancer will not progress. Isn't that sort of a reasonable expectation? Now, if I have a mental illness, now I may get something that is very forward-looking, or I may get something that's medieval, all right? And that's a moral outrage. See, that's a moral outrage. People deserve at least a basis of treatment that has some information connected to it. Now, why do I say this to you? Because you're out there doing the thing, okay? And yet you're put in a situation where, since we don't teach this stuff in academic training programs, which we really don't, you're put in a situation where you're either going to learn it on the job or you're not going to learn it at all. And you have to promote a culture within your organization that values your clients enough that the culture insists that you learn who Courtney Harding and John Strauss are. Okay? How many of you have read Len Stein's work or Marian Test's work from Madison? Some. A little bit? Some? Okay. You all should read it, and you should read a lot of it. Okay? Because otherwise we're asking you to treat cancer without ever having gone to medical school. You know what I mean? And it's irresponsible. So I don't want to just say this as a problem and then have you feel oppressed and bonded together in your oppression. That's not the point of this. The point is you have a right to the latest knowledge. You have a responsibility to go after it. But you have a right to go to your organization and say, we need this stuff so that we can read it, and we need time to read it, and we need, And it's the same thing with recovery. And so anyway, but I digressed. I apologize. This study is one of only 5 long-term studies in the world about what actually happens to people over the course of their life in long-term serious mental illness. Okay? And what this particular study did was to look at people who had been discharged from a psychiatric hospital, happened to be in Vermont. They looked at all the patients who had been discharged in a particular period of time. They went through their whole clinical record and re-diagnosed them and make sure that these were the people with the most severe and persistent mental illnesses, back ward situations, and so forth. And then they went out in the world and found every one of the people 20 years later. Every one of them. They found out who had died, and it didn't matter if a person still lived in the back hills of Vermont or if the person lived in Sweden. They found them anyway. They had a big federal grant to do this. And then they spent days and days and days and days interviewing every one of these people. And they said, please be a teacher to us and tell us how you've coped in your life with serious mental illness. Okay? So, now comes the pop quiz part. If you had studied all these people, and these were truly the most severely disabled people with serious mental illness, leaving hospital at a time when there was very little effective community mental health treatment in place, okay? Left the hospital in the late 50s, early 60s, and so forth. What do you think happened to these people? What's your best sort of clinical guess about what this group of the most seriously disabled who were deinstitutionalized, what happened to them?
A percentage of them carried on with their lives in spite of their mental illness.
A percentage carried on with their lives. What else happened to them?
Some of them lived.
Some of them lived. Actually, the great majority lived.
Yeah.
Yeah.
They learned to survive through hardship.
Some learned to survive through hardship. What else? Some recovered. What else? Some went through revolving door. Oh, come on, you're making this group sound like they look good in some way. And we're talking about people, backward folks, deinstitutionalized without much support, before there was much out there, and then we found them again 20 years later, the ones who hadn't died, what do they look like?
Same as they did 20 years before.
Same as they did 20 years before, not much improvement?
Probably worse.
Worse? What do you think? Mixture?
Yes, some would have done well.
Worse, probably worse.
Okay, there's 2 points here. One is we don't know. And you can't do your work effectively without knowing. You've got to know what the long-term course of serious mental illness really is. And the problem is the clinical literature doesn't show it to you. How many of you use DSM, what, 4, 5 now? You have to use it in your work, right? Up until DSM-3, that version, schizophrenia and other major mental illnesses, but particularly schizophrenia, which is the dominant one we're dealing with, was described as having a downwardly spiraling course which proceeded progressively, which was characterized by progressive deterioration throughout the life. Okay? That's what it said. And is characterized by the presence of either positive or negative symptoms which grow in severity over the lifetime. That's the DSM-3 definition of schizophrenia. Okay? It's wrong. It's wrong. And one reason it's wrong is it's based on excellent research, but it's based on research that's principally collected in crisis situations with people in hospital settings, in acute care settings. Okay? Now, if you think about all the times you've had a hard time in your life, think about if we only collected data during those times, and that's how we described the prognosis for your life. Okay? The revolutionary thing about Courtney Harding's research and John Strauss's is they looked at people's whole life, and they didn't look at them in crisis. They looked at them over the course of their life. And we need a lot more studies like that. Okay? I'll give you one quote from the study in terms of, I was just sort of teasing you, what did they look like? And this is a direct quote. According to Harding and Strauss, fully 2/3 of these people with the most serious mental illnesses were, and I quote, indistinguishable from the general population. Indistinguishable from the general population. 2/3. Now, what that meant is, if folks were living in a community where the level of income was quite low, their level of income was pretty similar. If they were living in a community where people were marginally employed, they were kind of marginally employed like the rest of folks. If they were living in better situations, they were better. Okay? But 2/3 of them, their situation was indistinguishable from the general population. And then 1/3 continued to have episodic problems. Okay? Isn't that completely different from the impression that we, And that, I think, is a much more, and that, interestingly enough, that study, the findings of that study, compare exactly with the other 4 long-term studies of, the other 4 long-term studies of major mental illness.